Welcome. Thanks for coming to the 2019 Triage Refresher. This counts as the telephone triage for nurses and phone screening for medical assistants competency for 2019. We're very happy to have you today. We will address question and answers at the end. So if we can hold our questions till the end, write them down. We will get to those. We're going to leave plenty of time at the end for some conversation. So again, welcome. Thank you all for coming. So without further ado, I'd like to welcome Jared Karen, nurse educator at Foundation Nursing.
All righty, welcome everybody. This is our putting the pieces together using protocols and telephone triage lunch and learn. For those of you who don't know me, as Julie just introduced, I'm Jared Karen, one of your nurse educators. I'm joined by the rest of the nursing leadership team who will be here. You'll hear at the end when we do the question and answer session. We have Amanda, Lisa, Beth, and also our intrepid project manager, Julie Sampson, who has conveniently disappeared as I introduced her. She's now in the doorway. Take a look. Quick note, please have your Thompson Triage Protocol book with you for this webinar. If you don't have it, now would be a good time to go run and get it. If you don't have a Thompson Protocol book, we'll talk about that later. We have no disclosures. Nobody's paying us to be here outside of Foundation. So good for you to know. Quick announcement before we begin. There is very shortly going to be an updated triage policy available to all of you. Now, if you're not aware, we did have a triage policy. We've had one for a long time. It desperately needed an update. Last time it was revised was in 2009. For a little context, that's around the same time that we were implementing Centricity EMR. So there's references in that policy to things like paper phone slips. Everybody remember those? Those are fun. So it needed an update. So it's been a 5-year process of multiple revisions until now we finally have a version that we're comfortable with and we're ready to update for all of you. Now, what does it mean? There's not a whole lot that you need to know about this. It really focuses primarily on scope of practice. And the good thing is we've been teaching these points for a long time. So it's not like a whole lot's changed, but the policy now supports that. So a few things that are a little bit subtle changes that you're going to want to remember. If you're a medical assistant and you're doing phone screening, the policy states that a provider must be on site for you to do that. So before that was a little bit vague, now it's very concrete. If you're going to be phone screening, provider needs to be on site. Now, also, if you're an LPN, we've talked about the concept of supervised triage before. We have defined that in this policy. Supervision means that the provider will final sign your notes. So we'll talk about why that's important in just a second. And then what's nice is that this policy also includes some very detailed documentation guidelines. So what, at a minimum, needs to be in your note and some additional tips on how to use the form that is available to you. So you will be able to find this in the Foundation manual on the Pulse under the heading Practice and Safety. It's not updated yet, but it will be. So your homework from this will be to go find that and read the new policy when it comes out. So quick review of the scope of practice guidelines that are in this policy and some of the subtle changes. You've seen this chart before, a couple of quick little updates that we just went over. As we know, the RN can do independent triage, which means you can do the whole process start to finish, and you can final sign the note. As an LPN, you still can do the full process of telephone triage, but the supervision, and this is important because the Board of Nursing requires us to define what supervision means if we're going to have LPNs triaging. So this was an important part of the policy that was kind of vague in the old policy. So we have made it very, very clear. The provider final signs your note. That satisfies the supervision for you as an LPN, protects your license. So, and then as a medical assistant, we've talked about phone screening in the past and how that's collecting clinical data from the patient, but it stops there. And then the only difference here would be that the provider would need to be on site for you to do that, so that you have somebody to consult. And then we include our clerical colleagues because they work hard in the call screening, making sure that the calls get to the right people. So just a quick FYI on that. Now let's get into what we really came here for. What are we going to talk about today? A couple of things. Number one, we're going to discuss kind of the elephant in the room. We changed triage protocol resources this year, and we're going to discuss some of the rationale and factors that influence that decision. We're also going to spend some time looking at some key components and features of that new tool so that we can get a little more comfortable with it. And then we're going to talk about protocol use in general. Regardless of what tool you're using, there are some key things we want to avoid doing, and there are also some important things to know, like when in the conversation do I bring in the triage protocol and use it? Is there a right way to do that? There is, and we'll talk about it. Well, we're also going to give you 4 practical steps that you can use this afternoon to use a protocol well. So those are some things you can look forward to. So let's begin by talking about the elephant in the room. In April of this year, we made a pretty big change. We discontinued the Briggs protocol book in favor of this book that you may not have seen before, the Adult Telephone Protocols by David Thompson. And it's an important thing for us to talk about because it might have seemed like, hey, we had this book, it was good, wasn't broken, why did we feel the need to change? So a couple of important reasons. This wasn't a snap decision. A lot of thought went into this. A couple of reasons why we did this. Number one, we really felt like this book in particular is a much better clinical resource for you as a triage nurse and gives you more support in your role, has better resources in it. It's also built on a different framework than the Briggs book. It is primarily symptom-based, which is better aligned with best practice. The Briggs book, we'll talk about those differences in a second, but it wasn't really the same approach, so we liked the approach of this book. It's also more consistent with our pediatric protocols. Now, if you're in an internal medicine or another adult practice, you probably didn't worry too much about this, but in a family practice setting, this was particularly difficult for people because you had the Barton-Schmidt protocol books, which are the exact same format as these Thompson protocols, and then you had the Briggs book for adults. And what was challenging about that is, as you all know, they're very different books, and they have very different format. So it was very hard for those nurses to get comfortable with both tools. And so what would happen is people weren't using the appropriate tool for the right population, and so we were providing substandard care. So we needed to make that a little bit easier and more consistent across the board. Now, no matter where you go, the protocols look pretty much the same, whether it's an adult or a child. And then, as a bonus, the book itself is a little bit more durable. I don't know how many pages I have taped to the back of my Briggs book. I think I have like 5 or 6. They just rip out really easy. And that's more of an annoyance, but it's also an important thing to think about. The longevity and the usefulness of the tool. It's made with thicker paper, a little bit more durable. But you may have noticed some differences in these books. And we want to call out a few things that may have seemed really obvious or concerning to you as you looked at the 2 different books. One of the first things that people noticed was that there are more protocols in the Briggs book. And you are indeed right, there are. There's almost twice as many. And there's some key reasons for that. Number one being that the Briggs book the Briggs book contains pediatric protocols. The Thompson book does not. That takes out a big chunk of them, right? It also contains OB-specific protocols, which the Thompson book also does not. It does account for pregnancy in the protocols, but it doesn't have protocols specifically for pregnancy. Also, something really important about this is the framework and the philosophy behind the Thompson protocols. They are 100%, for the most part, symptom-based. You'll find a handful of diagnosis-based protocols, but the rest of them are primarily a symptom-based. And the Thompson book wants to give you 1 protocol, for the most part, for a symptom, not 7. So one of the things you'd notice in the Briggs book is there's a lot of overlap, and it's not clear always which protocol to use. So an example of this, you have a patient who calls with indigestion. Your options in the Briggs book include indigestion, abdominal pain, chest pain, gas or belching, or heartburn. That's 5 different protocols you could use for that one situation. Now, there's no indigestion protocol in the Thompson book, but your main job is to determine whether it is upper abdominal pain or chest pain. You have 2 options. That's it. So that's more aligned with best practice in terms of actually figuring out what the symptom is and going from there, not worrying about whether it's indigestion or not, because that doesn't really matter in triage. You're going by what's happening in the symptom. Another big difference is the disposition categories. The Briggs book has 4 disposition categories. The Thompson book has 9. We felt that that gave you more flexibility and allows you to not feel like you're jamming a square peg into a round hole every time you try to fit one of the disposition categories to the situation. There's more than 4 things you're going to do, and so we felt it was more realistic. Also, a really important difference that we really felt was a good indicator of the superiority of this resource was the home care advice. Oftentimes in the Briggs book, the home care advice is very vague and ambiguous. You're going to notice as you look through the Thompson book that the home care advice is very detailed, very specific, and there's a lot of it. Sometimes multiple pages of home care advice for each protocol. So we'll talk about how to use that appropriately in a moment, but we felt that that was a much better resource for you than the very vague, often kind of fluffy advice that was in the Briggs book. So thought that that was a better approach. Now, a really important reason why we did this is that we were aware that these Thompson protocols are going to be built in and included in the Epic software when we get it next year. Briggs is not an option. So this change was going to happen. We wanted to get ahead of it. We wanted to give you the opportunity to learn how to use these protocols before you start learning how to use Epic. Can you imagine doing both at the same time? That does not sound fun to me. So we felt it was very important for us to get ahead of this change. And so we're about 9 months in, 6 months in, and we have about a year to go. So hopefully we'll be much more comfortable with these when they become the default when we get Epic. So let's spend some time actually getting used to these protocols. So let's take a few of these books and pass them to the people who are sitting away from the table, because we're going to open these up, and you can work together as small groups, because we're going to spend some time looking for some things in these books. And if you don't have a Thompson book, something you want to think about, you could use any book that you're using in your practice. Most of these sections exist in every sort of triage book. But if your practice treats adult patients, you should probably have a Thompson book. In fact, you should. Because it doesn't matter why the patient's calling. We owe them a certain standard of care, and this is the standard of care that we've agreed on as an organization. So please, if you don't have one or you don't know where it is, have a discussion with your manager, because that's important for you. So if you don't have it and you can't find it, open to the first protocol in your book, because that's all we're doing here is opening to the first one. So open up to page 3, everybody in the room, and look at abdominal pain, female. That's the first protocol in the book. We'd like to find a few things in this protocol book. So there's a list that's going to pop up here. I'm going to give you 2 minutes to, with your colleagues, find as many of these things as you can. Okie dokie. So time's up. Close book. No, you don't. So how many people found all of these things in the 2 minutes? Anybody have trouble finding one or more of those sections or pieces of information? That's totally okay. You can admit it. We're going to go through these one by one so that you have a good idea where they are and what they're for. So the first one that's listed is the definition of the symptom. Now, the point of this is to help you select the right protocol. This does not exist in the Briggs book. So it might be a little new as a concept, but what's nice about it is that it describes what the book means when it's saying abdominal pain, female. So it's useful for you. You're going to find it in the top left of the page right under the title. So that's pretty easy to find. But what you want to do is scan this, and if you notice that it doesn't really sound like what's happening with the patient, you're probably on the wrong protocol. But another tool that will help you is further down the page, you'll see something where it says see more appropriate protocols, a whole section, kind of a bold header. You're going to notice, though, that it's going to be underneath your emergency dispositions. So if you need to stop and call 911, those are going to be listed first. This is different than in the Briggs book where it just listed all the protocols at the top that you might consider. Another key difference here is that the Briggs book would just list a bunch of protocols. It's like, yeah, here's some options. I'm not going to tell you why you would go there, but here's some options. Think about it. The Thompson book actually tells you the symptom that might be happening and then tells you where to go. So you'll see the symptom, and then in italics, it will tell you where to go with the page number. So this is much more helpful to you because you may not know what falls under each. You're not going to memorize the table of contents. So this is really useful for you and gives you some practical tips as to what might fall under those protocols. Now, the next segment that we wanted you to look at was the assessment questions. This is a really big difference between the Briggs book and the Thompson book, and it's a really important difference. I think it's where a lot of people are getting tripped up with the Thompson book because it's new, it looks very different, and it's formatted differently than the Briggs book. Now, the Briggs book had a horizontal orientation. It was left to right, so you'd have your category of your disposition. It would list the symptoms, and then to the right, it would tell you what the disposition was. This is different. It's vertical. So you have your disposition in bold as the header, and then the symptoms that go with that disposition are listed below it. Another key thing that I think is sometimes makes it a little more difficult with this book is that the wording is not phrased as a question. In the Briggs book, it was very much like, are any of these things happening? And it was with a question mark, and it made it, you could literally read the book to the patient. You can't do that with this book because it's built like a checklist. It's there to remind you about things to ask about, but it's not going to tell you how to ask the question, which again, better aligned with best practice. We don't want to be reading the book to patients. We should be using our critical thinking skills to get the information from them. So it's different. It's going to take some getting used to, but just know that that's how it's arranged. You have your disposition on top and your questions in order, top to bottom. So another really important and useful feature, and if you didn't know what this was, you might not look for it. There are rationales provided with the questions. Again, this is a feature that does not exist in the Briggs book. You'll see it underneath where the symptom is. It's going to give you in italics on some of those questions a reason why you're asking the question. This is really useful. It helps you to remember the questions to ask. It helps you to understand the assessment you're making of the patient so that you're not just blindly asking questions just because it's on the page. We felt like this was a really useful resource for you. So in this case, you can see that this question in particular is asking about a fever greater than 100 degrees Fahrenheit in a patient who's bedridden. And it's reminding us that the reason why we might ask that is because the patient is at a higher risk for a bacterial infection. And then it also reminds us that, hey, by the way, they might need an ambulance because they're bedridden. So there's some nice cues and reminders built in. Look for it in italics underneath. You might also see statements with the abbreviation capital R/O. That means rule out. It's saying that you're asking that question in relation to a specific medical condition. So that helps you to understand the reasoning and the clinical reasoning behind it. So feel free to use them as cues. Recognize what they are and know that they're there in your protocol for you to use. Now this is something that exists in both books, first aid advice, pretty standard triage protocol stuff, but it's useful to know where to find it. It's in a very different spot than in the Briggs books. It's actually in two places, so we're going to show you both here. The first one is probably the most convenient, and that is right in line with your 911 dispositions. If you need to call 911 and there's first aid advice that goes with that reason, it's going to give it to you right with it, so that you don't have to go flipping pages to find that first aid advice. So that's really useful. And then a second place you'll find it is actually at the end, after the home care instructions. So you'll see the home care advice, and then there'll be a section right afterwards that says first aid. And it will list all of the first aid situations and the instructions to give to the patient. So just recognize it's going to be in two different places, and that redundancy is there on purpose so it's easy to find. Speaking of home care advice, this is a big difference between the two books and something that might throw you for a loop because there's a lot of it. So you'll notice there's a section after your protocol with a header. It says home care advice, and then it has a bunch of bullet points with some information, and you might see that there's 2-3 pages of this stuff. Don't freak out thinking you have to tell your patient all of them every time. It's meant to be a toolbox for you. You're going to notice that the instructions are much more specific and direct. You're going to feel more confident giving that advice because it gives you more details, but it is built around the framework that we know that patients aren't going to remember more than 3 or 4 things. So the book itself even tells you, pick a few. Don't try to do them all. So just know that that's there. It supports your judgment because it gives you an idea of when and where you might need to use those and gives you enough information to really feel confident with those instructions. Now, an important section of the home care advice, and this is very different than the Briggs book, is the callback instructions. Briggs book put this in a little red box in a separate part of the page. This is built into the home care instructions. It's always the last item. So this is an item you never want to skip in your home care instructions. So just make sure that you know that that's where it is and that you're going there. And make sure that you give them all of the items. Don't skip items in this section just because you've kind of feel like it doesn't apply, they need to know all of those, but don't feel like you're limited to that list. You can add additional instructions if you feel it's relevant to the patient. So things to know about those protocols. Now, one section that is really a gem in this book is the background information, and there's nothing like this in the Briggs book. We really feel like this is a really important feature of these protocols is this gives you clinical context information, stuff like what's the worst case scenario with this symptom? What's a common workup for the symptom? What are some possible causes? So that you can have the clinical background information, and it's short, it's concise, it lets you quickly self-study on the fly while you're on the phone with the patient, and you might even find it to be useful as teaching points for patients if they're questioning your decision making. So this is a useful section. You might try reviewing it right before you pick up the phone or after you hang up the phone on a call that's a little difficult and you're like, I don't really know that I handled that well. So it's a useful tool for you and will help support your development of skills. Hope that you guys get the opportunity to practice and find these things and use them in a real call, because that's when you're going to start to feel confident about the tool you have with you. But all of this kind of begs the question of why on earth are we doing this anyway? I'm a registered nurse. Why do I need a protocol in the first place? Right? What's the important part? Well, you know, all of us have bad days, and it's really meant to be a safety net. Even Sheldon has a bad brain day every once in a while. So it doesn't really matter how smart you are. This is a tool that helps protect you and helps to support your practice. So it gives you cues and reminders. It works like a checklist. And it really prevents you from making a poor decision, but it doesn't guarantee you're going to make a good decision either. So it's a balance. Think of it like a safety net. It also helps promote a consistent standard of care through the whole organization because we do use the same protocols across our practices. So if we're going to use protocols, though, are there some things that we want to avoid? There definitely are. So here's some things you want to think about and avoid doing. Number one pitfall, over-reliance. We talked about reading protocols to patients earlier. That's like the extreme end of the spectrum of over-reliance, right? The protocol is there as a safety net, but some people use it like a crutch. They lean on it. They let it tell them what to ask the patient. They let it drive their assessment, which is not the correct way to use a protocol. If you do that, you will probably get through the call. You may not have adverse outcomes, but you're setting yourself up for failure down the road. Eventually, something's going to happen where that protocol is not really going to hold up. You need to use your critical thinking skills. So another big piece is using the wrong protocol. This is directly related to not having a complete symptom history before you open the protocol, which we'll talk about in a moment. Big one is skipping questions or sections. This is, remember that we said it's a safety net, and it's there to prevent you from forgetting things. If you make a habit of skipping or cherry picking questions out of the protocol, you might as well throw it out the window. It's not helping you because it's there to prevent you from forgetting things. So if you intentionally leave something out, you're not using it to your advantage. So just remember that those things are there to help you. Don't throw it away by picking and choosing. And some common sections that people tend to skip or miss in the protocols are listed here as a reminder to make sure that we're at least scanning those sections during our call. And then this one comes directly out of the literature. We didn't make up that phrase. Failure to listen to the patient. Sometimes we get a little locked in triage and we're like, I got to get through this protocol and ask all these questions and get off the phone with this patient because it's taking forever. But we have to listen to what they're saying and really think critically about the situation that we're seeing unfold in front of us. So it's important to remember that. It's a process, it's a conversation. It's not just checking boxes and going down through your questions. So, quick quiz question. Let's talk about all things not to do with the protocol. So let's let you guys show off and see if we can identify the correct way to read a protocol. So 3 options. A, read each line verbatim, top to bottom, exactly as it appears. B, just pick the ones you think fit. Seems like a good idea. Or this, read the questions in random order. Keep them on their toes. What do you think? A. I have 1 A. Going once. Going twice. Anybody disagree with that?
Agree.
Agree? So I'm sorry, this is a trick question. They're all wrong. None of the above. These are all wrong. What is the right way? Well, the first thing that's really important to understand about using protocols is that it's important when we use the protocol. When in the process do we bring the protocol in? And it's really useful to think about the data collection, your interview of the patient, getting that information out of them as 3 separate phases. The first phase is the shortest phase, and that's the emergency survey. Your goal during this phase is simply to identify if I need to hang up, or not hang up, stop the phone call and call 911 right now. That's your goal there. So this is usually the first 45 to maybe 60 seconds of your phone call. Very short. You're not necessarily asking a lot of questions. You're trying to get a quick picture of the situation and decide, do I have an immediately life-threatening situation that we need to deal with right now? If the answer to that is no, then you move on to your second phase, which is the symptom analysis. Does that sound familiar? Does anybody know the tool we might use during this phase of our conversation?
Old card.
Say loud.
Old card.
Old card, right? So we gave you some mnemonics last year when we talked about telephone triage. We talked specifically about symptom analysis and symptom history. If you want a refresher on that, the recording is available on the Pulse. You can watch the whole thing. We go in depth about how that works, but you have mnemonics. You can use old carts or phosphate. There's a few others that are out there. But the idea is it's a mental checklist to make sure that we get a complete history of the symptom. And that's actually the first part of your triage call. And that takes critical thinking to ask the right questions. And now the third, once you have a complete idea of what's going on, a good clinical picture, then we move on to the third phase, which is the protocol screening. We bring the protocol in, and this is there to prevent us from forgetting stuff in the symptom history. So notice that this is at the end. That's intentional. So it's really important to remember that this is the last phase of your conversation, of the data collection part of it. So to look at what we're going to do with the protocol, though, there's really 4 steps that you want to remember. And I'm going to say it again. We're going to say it a couple of times. The symptom history comes first. Make sure you have a good history before you even look at your protocol book, because that's going to make sure you're on the right page. You're also going to find that following this process makes your use of the protocol more efficient, and we'll talk about why in 2 seconds. Next, you're going to select the protocol, because once you have a history, you know what's going on, and you can pick the right protocol. If you just go in blindly and pick a protocol, it's pretty likely you're going to land on the wrong page, because the first thing they tell the receptionist is always the thing they're calling about, right? So then the next phase, what do we do next? Do I just like open it up and start asking questions? Fire away? I see some heads shaking. So maybe the instinct is no. What do we do next? We're going to scan the protocol, top to bottom. And your goal here is to find the stuff you haven't already talked about, because you just took a history from the patient. So the goal here isn't to ask 20 questions and just, badger them with pointless interview. The goal is to use that protocol to support your decision making. So you're going to find that if you've taken a good symptom history, by the time you get to the protocol, a good chunk of that information you already know. So you're just checking that out. Yep, I know that's not happening. I know this is happening. You may need to ask questions to clarify. You might say, well, we didn't address that specifically. That's what you need to know to ask. So then once you have a good idea of the things that you're going to go after, then you ask your questions. But you need to make sure that they are in the order they appear in the protocol. Because again, the protocol is arranged from what's most life-threatening to what's least life-threatening. So you do want to make sure that you're not necessarily blindly following the protocol, but don't mess with the order. And then again, you may need to clarify their responses. It's not always a yes or no question. You may need to kind of try to get a picture of what is happening so that you can understand whether that symptom is there or not, especially because some patients aren't going to understand the language in the protocol book. It's written for you, not the patient. So just remember that. So 4 steps: take your symptom history, select your protocol, scan the protocol, then ask the questions that you have not already answered. So once you've done that, the protocol is going to guide you into a disposition decision. And so we're not going to get into all the ins and outs of how to make a great plan of care over the phone. That's like a whole other presentation. But this is more about how you're going to use the protocol to help you select that disposition. The big thing is, if the patient says yes to a symptom or it is happening, that's where you stop in the protocol. And that disposition, remember in the header, is what you're going to be recommended to do. Now, sometimes you may feel the need to deviate from the protocol. If you're going to do that, the best practice approach is to move the patient up to a higher level of care, not down to a lower level of care. That's much harder to defend. So that's just something to keep in mind as a rule of thumb. Now, of course, a provider who knows the patient well may choose to make a completely different decision, and that's totally okay. They can override the protocol. Protocol is there to support your decision making, but again, it doesn't guarantee a great decision. So if you feel that maybe the protocol is being a little alarmist or it doesn't fit the patient, maybe that's a good opportunity to have a discussion with the provider. And then the next step, of course, you're not done just because you have a disposition. It's to make a plan to make that happen, right? We know where the patient needs to go. Now we have to figure out the how. How is that going to take place? And that's where the rest of your conversation focuses. Once you have the disposition, it's how are we going to make that happen? So just remember as you do that, that the best plan is the one the patient's actually going to follow. So the big thing here is to avoid giving cookie cutter advice. So just remember that. And a few things. A question that we get all the time: can medical assistants use triage protocols? Because we've talked about how medical assistants do phone screening, collect the data, but they don't make the decision. So does that mean they can't use a triage protocol? A couple of things. Number one is that we know that making an assessment or choosing the disposition is outside the scope of a medical assistant. And that's now supported by our policy. So secondly, though, we just talked about how valuable the protocol questions are for preventing us from omitting things or forgetting important information. So it seems like they might be a useful tool to a medical assistant who's phone screening. So I'm not going to say you can't use the protocol book, but if you're going to do it, there are some extra cautions you have to take. Be aware that there's going to be a lot of information on that page that's just not for you as a medical assistant. There's going to be stuff on there about what disposition to pick and what advice to give the patient. That stuff you kind of have to ignore. But you can still use the information to help you take a good history and to inform your conversation with the provider. But if you're going to do it, also keep in mind the pitfalls we talked about. Ask all the questions. Don't skip and pick and choose. Document that you're using the protocol. And the principles are still the same, regardless of your scope. So a few takeaways, things that you can do this afternoon when you go back to your practice to improve your skill with protocols. Number one, if you're new to the Thompson book and it's been uncomfortable, we know. And we appreciate that it is difficult to change tools to get used to it. But the thing that's going to make the biggest difference is practice. Practice, practice, practice. Use it with every call. Get used to it because it will get better. We promise. You'll get more used to it. You'll get more confident in what it's telling you to do. And then another thing that you're going to want to do is to get in the habit of taking your symptom history before you reference a protocol. This is going to feel uncomfortable at first. It requires you to really focus on what is happening in the conversation and think about what the patient is telling you. But it will pay off dividends as you become more efficient with using protocols, as you make better decisions because you have a more complete picture of what's happening. And then use the protocol to fill in the blanks, to finish your history and direct you into a disposition. And then take advantage of all the features of your protocol books. It's not just there to give you a list of questions to ask. They are really robust clinical reference tools for you to use right there in front of you. Take advantage of things like background information, question rationales, and home care advice to enhance your practice. So we're not done talking about triage. We know it's really a big topic. We can't cover everything in an hour over lunch. So some things that will be coming soon in the future. Documentation. Big questions we get from everybody about documentation. We'll talk about that. We'll also look at how we create a good plan of care over the phone, beyond just does the patient get an appointment or not, because there's usually more decisions involved, right? So those will be coming. I'm not going to promise a timeline, but they're coming. So keep your ears peeled for that. And then a few things in the meantime. You may want to develop your skills, and we want to help you with that. So we're going to give you a couple of options, some recommendations of ways you can improve your skills. Some recommended reading We highly, highly, highly recommend this textbook. Well worth the investment. The Art and Science of Telephone Triage, How to Practice Nursing Over the Phone by Carol Ruttenberg. This is the eminent textbook on telephone triage. It's the basis for probably 95% of this curriculum. So it gets into a lot more depth, and there's just so much in there that we can't cover that it's a really useful resource for you. You also get a discount if you are certified in ambulatory care nursing or a member of the AAACN. Also, there's the core curriculum for ambulatory care nursing. That's more of an all-purpose text, but it will help improve your clinical knowledge to help you practice better in telephone triage. It also covers things specific to telephone triage, so useful to you. And then we always recommend that people get familiar with the scope and standards of practice for our specialty in ambulatory care and telehealth nursing, so you can understand the standards of care that apply when you're on the phone with a patient. And then some courses that you might think about taking. One is coming up very soon. It's by Wendy Wright, who's a nurse practitioner, a speaker, and a consultant here in New Hampshire. She does a telephone triage course every year at St. A's through their continuing nursing education. It's about $100. It's a full day, and it gives you several CEUs. It is well worth every penny. I had the privilege to go last year. I know Julie's gone a few years ago. It's phenomenal, and she's a great speaker. She's entertaining, fun to listen to. If you can get the day to go do it, strongly recommend that you do that. And then there's also the certification review course for ambulatory care nursing through the American Academy. That covers, of course, a lot more than just triage, but it will help support your development of skills. And then there's also past conference presentations from the American Academy, which are generally anywhere from $30 to $100, depending on the package you're purchasing from them. They do offer CEUs. They're cheaper if you're a member, and you can look at them by year or by topic. Telephone triage is always covered at their conferences because it's a big part of what we do. So definitely check that out. And then if you are interested in a bonus or an Easter egg, you can take a look at the 2018 program. Look under Transition to Practice. You might recognize some names and voices. Just saying. So that's going to wrap up for our session. Are there questions?
So if they're, as the care coordinator, triage is a little bit different because we know our patients very well. I can think of an example exactly where a patient calls and the triage book would tell me she needs to go to the emergency room, but that's not the case for her. She goes to the emergency room every week, and usually we can work it out in the office. So if I make my disposition based on knowing her and the symptoms she's presenting to me, and it's not what the triage book is telling me, is it sufficient enough to route it to the provider for code signature, or do they need to further?
Yeah, so there's a couple of things that you might consider in that situation. So having the provider's backup is always helpful because they're making a medical decision, and they might say, you know, it's more appropriate to bring the patient into the office for this. The other thing is, as a care coordinator, you might have a plan of care in place for that patient, and that plan of care might say, when these symptoms come up, we're going to bring you into the office. And then that's a little bit different than just the triage protocol, right? So that's why it's sort of important as a care coordinator to document that plan of care, because you might be able to point back to that and say, we have a plan of care in place. These are the criteria we have, and they're meeting that, so we're following this established plan. And so there is a balance between nursing judgment and the protocol. It's not as concrete as always follow the protocol and you'll be okay. That's not true. But also, you don't want to be winging it either. So there's no really like nice, easy black and white answer to that. But you know, generally, if you're acting in the best interest of the patient, that's usually you're going to be okay. This is your chance, guys. Anything you want. What do you got?
So you said to gather your symptom history first.
Mm-hmm.
So now I have the patient on the phone, and they're talking, and how can I listen and go through and select the right protocol?
Yes. So that is that was really the topic of our previous refresher last year when we talked about symptom history. So you could certainly watch that. But for a short answer to that question, that's where those mnemonics can help you. So the old carts and phosphate mnemonic, they are like a checklist. So as that patient is sort of gushing, telling you everything about their life, you're going to look at that as your checklist, and you're going to check things off as they tell them to you. And then when you when they take a breath, because eventually they have to breathe, you you can use that opportunity to clarify. So you can, a good strategy is to reflect back to the patient what they said. It sounds like this is what's happening. I'd like to know a little bit more. And then you go back to that old carts or that phosphate, and you go and you ask questions about the things they didn't tell you. Okay. Or you clarify where the details are fuzzy. You said it started last week, but then you told me something about last month. Which are we talking about, right? Because that happens all the time. You got to clarify the timeline. You got to figure out the details. And that's where you can use that opportunity. So it's a balance between letting the patient talk and then taking control and kind of redirecting, but that's where that tool will help you. Ask me anything. Almost anything.
What's your sign?
I don't even know the answer to that question.
Do you plan to knock over that thing behind you by the end of the day?
Oh, probably.
Oh, okay. This is a little risky question, but sometimes what I do when I look at the original call from the patient, I think of a couple of possible areas that I might, or protocols I might look under, and I'll stick a piece of paper so that when the patient's talking a mile a minute, it's easier for me to go to once I kind of pin down. Is that bad? Because I have like kind of already pre-thought where I might go without talking to the patient. Should I not do that?
So there's not, it's not so black and white, right? So like it's not, there's nothing wrong with anticipating what might happen and where that call might go. The reason why we don't talk too much about that is it's kind of an advanced skill. So for a beginner, the pitfall is I'm going to open in the protocol and just read what's there, right? If you're looking ahead and you're like, okay, so they're calling with this, it might be this, this, or this. I'm going to take a quick look at those protocols, get an idea of what I'm looking for, and certainly take a look at what might be the immediate emergencies that you need to deal with. That's totally okay. You're just preparing for the call. But what you don't want to do is get sucked down the rabbit hole of following the protocol without really having a good idea what's going on first. So it's just a good habit to be in, even if you glance at the protocol for some information before you start, that you kind of put that to the side and ignore it while you're having that first initial conversation with the patient. So.
I think, too, that it's really important to make sure that you have an open mind about where the call goes, because you may think that it's going to be one thing, and then you get on the phone and it ends up being none of those three things that you thought.
Yeah, that happens
and
all
what
the
happens
time.
a lot, what happens frequently is somebody's like, oh, I'm going to get to the sore throat page, and then they only like half listen to what the person is saying and completely missed that it went into a whole nother direction. So it's really important to just not get to like allow yourself to be wrong. Okay, I did look up that page, but I was wrong. This is where it went instead.
That actually happens probably more than half the time.
Oh yeah, well, they just don't give the correct information sometimes too.
Yeah.
I mean, I've had a patient call to ask about, am I having a reaction to a medication, and it ended up he was having a stroke. So, you never know.
Okay.
There's a really great example in the Ruttenberg book. She has a lot of real life stories and exemplars, and one of them is about a woman who called a primary care practice about arthritis pain, and she loved to garden, and so she spent more than 20 minutes on the phone with the nurse talking about ways to manage her arthritis pain for gardening. At the end of the call, and this is another advanced tip that's not directly related, is the nurse asked the question, is there anything else I can help you with, which is a really important thing to make sure you ask. The patient revealed that the real reason she called was because she was concerned about an HIV exposure, potentially. She was testing the nurse to see if she could trust her. And so sometimes it doesn't come out until the last possible moment in the call, and then you find out the real reason why the patient's calling. So it's a good example of what you're talking about. And sometimes you just have to be flexible. So here's your chance. We got time, guys. A few minutes anyway. And this is like open forum, not just about protocols. If you can think of anything triage related, fire away.
I just want to make a comment. And for years, I did use Barton Schmidt, and it was I could never assimilate to Briggs. It was too difficult. And so I was really excited when I saw the format of Thompson. I do a lot of triaging and immediate care, but I love to still refer back to Barton Schmidt, and there's a lot of similarities that you can pull over to adult medicine. But I can say 100% certainty. Every time they came out with a new version, it was really hard to switch even to the new version. I can't tell you all the markups and the inserts, and I mean, it really becomes like your go-to, and to the point where providers were coming and, you know, looking to see what Barton Schmidt had to say. So I think this is so worth embracing. I'm so excited that you did it, because I think that the format is just so much better from a nursing standpoint. It just makes more sense. So I'm really excited about it.
Great for sharing that.
Yeah. Yeah. I have a hard time throwing old versions of Barton Schmidt. It's like, how do I read it out? Because I really invested a lot in, you know, in that reference. So these are really to be have highlighted.
When we get the new edition, we'll give them all to you for your collection. So another thing that I didn't mention about the Thompson book that's really useful is if you're trying to get used to it and you're just like, this is so different, it's hard, I can't figure it out, there's actually a section in the back of the book, how to use this book. It's great. It's not just like here's what you do. Like, it's actually a small book on its own that actually has a lot of really good stuff about triage in general, but also about how the book is constructed and how to read the different sections. Very useful resource. When you have some spare time, feel free to scan and or read that, but that might help you as well.